Pharmacy Frontiers podcast. Today, we're excited to come to you with Dr. Annie Eisenbeis, the Director of Pharmacy Practice Development at MPA and the CPESN Lead Network Facilitator. But first, let me remind everyone that the Pharmacy Frontiers podcast is available for streaming on your favorite podcast streaming app, whether it be Apple, Podbean, Spotify, or YouTube. And the Pharmacy Frontiers podcast is dedicated to the pharmacy profession. And the comments and opinions shared today are those of myself, our guests, and are not official statements of the MPA, Mercy, nor Mitchell Pharmacy. I'm Daniel Good. I'll serve you as co-host along with Tim Mitchell. And now let's welcome Dr. Annie Eisenbeis.
Yay! Well, welcome, Annie. We're so excited to have you on this. Like I was just saying before we got started recording, this is going to be the #1 podcast of 2026. And you have a good start because this is our first #1 podcast of 2026.
Yes, starting the year strong.
Yeah. So we're just so excited to have you here, and so many cool things going on in Missouri, and I'm so glad to talk about it. But first, we want to get to know Annie a little bit. So Annie, kind of give us your kind of where you started, back in the beginning days of pharmacy. Don't take too long because I know your story will probably be a long one, but fire away and give us a little background of what you're doing and then up to today.
Yes. Okay. In my 10-second elevator pitch mode.
Yeah.
I'm good at this. All right. So started off in St. Louis, working in community pharmacy chain in St. Louis, and then moved to Central Missouri to live in Columbia, but then worked for Christian Tadris at Sam's Health Mart in Moberly.
Another rock star.
Yeah, so this was about a span of 5 years or so working in community pharmacy. So now I can say in both urban and rural settings, and both chain and independent. And then MPA opened their first executive fellowship in association management. And I looked at Christian and I was like, oh, this looks like right up my alley. He's like, I know. So he let me go and do the fellowship. And unfortunately for Christian, or fortunately, moving all of pharmacy forward, hopefully, that I carved out a position at MPA while on my fellowship. So created the position of Director of Practice Development and have been here ever since. And that was, I think, 2018. So like now 6 or 7 years here at MPA.
Yeah, that's amazing. That's amazing. So, yeah, I'm just amazed at it. I mean, you did really good, by the way. I mean, you covered that really quickly because I thought this would be like a 5-6 minute thing.
That was the cliff notes.
I know. I remember when the transition happened. Christian was like, "Oh man, I'm going to lose one of my pharmacists." And I'm like, "Annie?" So, but you did help him out a little bit afterwards as well, I think, didn't you? You just kind of
yes. I think up until my daughter was born, I was PRN and really worked most of the Sundays because I knew that was not the one that anyone else wanted to always work. And it was one that I felt like if it was slow, I still knew things that needed to be done and could help out where I could. Also, some of my favorite technicians still worked on Sundays, so I could touch base with them and see how they were doing.
Yeah. Go ahead, Daniel.
Your face is really becoming one of the most recognized pharmacists in the state now. The work you've done with the schools of pharmacy and the work you've done through MPA, it really is a testament that we're looking to you to be that next generation of leadership. So thank you for stepping forward and filling that role.
Absolutely. I have great leaders to look up to.
So take us to CPESN. First, for our listeners, just tell us what CPESN is, and then tell us about your role as the lead network facilitator.
Absolutely. So CPESN is a clinically integrated network. And for pharmacy folks, that means that any pharmacy, community pharmacy that wants to join can, as long as they meet minimum requirements. And those are minimum service requirements. So those that are interested in enhanced services, meeting some of those minimums, immunizations, delivery, face-to-face interaction, things that most community pharmacies would meet, and then enhancing on those. So With the clinically integrated network component, that means that we can contract differently. It allows those pharmacies to get together and say, we want to provide XYZ services, and we don't have to do it individually. And we don't have to sign as a giant national operation either. So we can contract with employers, we can do grant contracts, we can contract directly with health plans. And provide services that maybe aren't always turned on for pharmacists as well, quote unquote, in the medical billing space. So we can also have a space to prove that pharmacists should and could be providing these services and that they're incredibly impactful in doing so. So we've had great success with our CPESN-Missouri network in leading a lot of initiatives for the nation and other local networks. I'll also add CPSN has a lot of really interesting infrastructure. So we have our USA umbrella. So if there were a need for a national contracting opportunity, that exists. But also that allows us to kind of piggyback off of some other states and what they've done with some of those partners already. So for example, a health plan isn't starting the contract from day one. We can piggyback off of a master service agreement that might already exist with another state and then change what that scope of work looks like based on what the needs of Missouri and the needs of Missouri's patients are that our pharmacies are able to fill. The last thing is it's a network of networks. So it's really based on the local relationship. And really everything that has been successful in our network is based off of a local relationship. And I am diving deep into that terminology. It's not just the pharmacy knows the hospital or the pharmacy knows the payer. It's Tim Mitchell coaches soccer with the payer's, daughter, and then all of a sudden we're in conversations. So it's really based on, I think, too, that local relationship and also the trust factor that exists in knowing the people that you're working with and the pharmacies and pharmacists that you're working with. What am I missing? Let's see. CPSN is the clinically integrated network also allows us to single sign. So we can sign a single contract and pharmacies that are eligible can opt in, or if they aren't able to or interested can opt out. And let's see, it's under the MPA umbrella as well. So we have a local network now. Missouri is our local network built on the geography of Missouri's lines. But there's also some special purpose networks. So our network is fully immersed as well with a special purpose network, CPSN Community Health, in focusing on addressing social determinants of health and closing gaps in care there by training pharmacy technicians as community health workers. I hit everything, but that's it in a not a nutshell.
Yeah, well, and just
in there.
Yeah, just all the things that CPSN is bringing. Now, these are non-dispensing activities, right? I mean, they're related to dispensing, but they're not directly related. They're indirectly related, I guess. So.
Yes, I think some of the success of our network has focused on what can we build off of the dispensing foundation. So that's a service that all of our community pharmacies offer, and it's actually one that provides a niche area of patient access and reaching patients differently. So we're not trying to kind of replace any other type of provider. We're really filling gaps in monitoring, follow-up, and longitudinal care, and then being able to support from when the patient sees their PCP to when they see them next, the in-between care, as we call it.
So, and I know we've talked about this before, but when pharmacists talk to patients, I know I talk to my patients probably 30, 40 times a year, the ones that get regular medications. And so that's such, and my technicians are right there with that as well, with our sync calls and, all the different things that we're doing, checking in on them and so forth. Their physician's office may see them 2, 3, 4 times a year, maybe if they're lucky. Tell us a little bit about, how we talk to payers about the value of what pharmacy brings, because I think that's sometimes a hill to climb because they don't understand the whole concept. They just think we're filling prescriptions. Tell us a little bit about kind of where that's going.
Absolutely. Yes. So you're right. Payers, partners, the like, put pharmacy in a box. They think that the solutions that we bring to the table are medication access, which we do bring these to the table, but we do a lot more on top of that. It might be, specialty pharmacy navigation or formulary navigation. And those, again, are things that we help with, but I think those are just the foundation and they're built into that dispensing foundation. The things that we talk to payers about are proactive patient engagement and longitudinal monitoring and follow-up in exactly what you mentioned, Tim, those 5 to 10 minute interactions that happen multiple times a month. And so we're able to better touch base or connect on issues that we didn't even know to ask about, especially those related to non-medical drivers of health or the social determinants of health. I think this has really come up, especially in the employer space, for example, in them asking, how can we ask our employees if they have issues with food insecurity or transportation? That's not something I feel comfortable asking my employees. And I'll say you shouldn't. It's also not something that people are going to ask on a cold call. So if you bring me an assessment to say, what social drivers of health do I have that need to be addressed and where are the barriers, I'm probably not going to understand your questions or answer truthfully, just out of multiple things, but the trust factor has to be there. So, but when the pharmacy calls me to deliver my medications and I say, let's hold on that one this month, I'll get it next month. That's a very easy conversation to dive a little bit deeper into, to say, wait, what's going on? This is one of your chronic medications that you need. How can I help? Or what are the barriers to getting this medication? And then I'll also add on the delivery component that no one has seen this yet as home visits, that we have access to patients in their homes and can support them whether they leave or not. And this has actually come up recently on a discussion. We had a payer, we were talking to them about fall risk assessment and stroke risk assessments that we did in patients' homes. And they said, how did you do that in their home? And the pharmacist I was with said, we drove there. But what the payer meant was not how did you get to their house, but how did they let you in? This was not a cold call type situation. We deliver to them all the time, whatever they need, whenever they need. And so this wasn't this awkward, hey, can we come in and do this random assessment? This was, we're dropping off your medications. Can we come in and make sure XYZ is okay? And so that, I think, is that trust factor, the local factor, and being able to address needs very succinctly, because we can connect with that patient so many more times in their day-to-day activities and month to month.
Yeah. They know the person that's coming to their door. And, if someone's calling them from a call center in wherever, Arizona or wherever, and then they're sending somebody that they don't know, maybe from Kansas City down here to Southwest Missouri to visit them. And we come to their house probably once a week, twice a week, sometimes, to deliver their medicines. Oh yeah, Tim's going to come over, or the community health worker is going to come over. That's the person I talk to every time I need to make sure my medicines are set up properly. So such a huge win. I know I always think about the story that Tripp told, that he's talking about, he was talking, I think he had a conversation with somebody that was like, well, we've been trying to get a hold of this person. He goes, well, my technician knows so-and-so, and they go to church with him, and we're just going to send the guy over to have someone take a look and make sure he's okay. And he couldn't get out because a tree had fallen down, a storm had came, and they went over and got the chainsaw, cut it up, and he hadn't made a phone call. He just, was hanging out until somebody came and cleared his door. So anyhow, I think, those local relationships are so valuable, and
yes,
payers need to know about that. So.
I think too, there's so much to be learned from where and how and what's in someone's home. Because leaving and going to a doctor's office, there's only so much that they know to share. And unless those questions are asked, they might not know to share that information. One of my favorite shows is called The Midwife, and the midwives, and this was back in the 40s in England, going and visiting patients' homes, but seeing what type of care they can provide, what type of, things they have access to. It kind of almost goes back to if you ask a patient how or where they're storing their insulin and they say the fridge, and then you go to visit their home and their fridge isn't plugged in because they're trying to save on electricity bill. There's things like that it's like, I wouldn't know to follow up unless I saw it in real life. And yeah, so I think those are some very impactful interactions that happen that we don't even realize that we need to be sharing with the world.
So Annie, that a lot of those kind of operational decisions are made by the pharmacy owner. Well, what is the payback? What's the financial incentive for them to take on this kind of responsibility?
Good question. So right now, there's kind of these two options I see for payment models or reimbursement for pharmacy services. You have your PBM dispensing, and then most others see medical billing as the other option. Well, we see that there's a whole host of opportunities in between. We don't need to turn on, I mean, we do eventually, but we don't need to wait to turn on CPT codes for pharmacists to be able to bill medically. We don't need to wait and train everybody and the payer when and how pharmacists are going to bill for these services. We can do that right now by contracting directly with a plan and saying these are the services our pharmacies provide. Additionally, then we can aggregate that information to be able to then share what the value was, what the outcomes were, how did we improve quality metrics, for example, because we're not just billing down here fee for service and sharing just the claim information. We're also then able to show all of that outcome and information as well. So I think from the point of view that I see it's all of the in-between and the areas that pharmacies can impact and then show that value, it also allows for some of the value-based payment mechanisms that don't exist in one or the other. So it allows pharmacies to also help plans and pharmacies get a bonus payment for meeting some of those metrics and really focusing on the quality of care that patients receive. And it might even just be in those 5 to 10 minutes, but because the pharmacy can follow up so many more times, they make sure that it remains quality care and that patient is taken care of by the end as well.
Well, I think it's important that store owners, because they ask me this all the time. Well, what kind of return on the investment? I mean, Daniel hit it right on the head. I mean, what's in it for the stores per se? You know, I get it, and it is an investment. And in today's market, we have to have some kind of return on it. So tell me some of the big wins that you've had. I know you've had some.
Yes.
And I have store owners asking me all the time, well, what value do you see in it? And I said, that is our future. But tell me, and we don't have a whole lot of time, but go through some of those big wins.
Yes, our biggest win was in 2024 with our Missouri Pharmacy Vaccine Gap Closure Program. We were focused on a 5 to 15-minute vaccine hesitancy education intervention, and it was all based on a CPT code that was not turned on for pharmacists and pharmacy teams to submit claims for. So it was a $25 intervention. We had over 120 pharmacies submit interventions in a 9-month period, over 100,000 interventions submitted. So we were able to pay pharmacies over $5 million in a 9-month period, but also the impact was substantial. So we're still sharing with payers and partners alike in Missouri and outside of Missouri, those that are interested in coming and participating in something similar. Also, I think for that program, it was a foundational program. So the interventions that we included are things that we can build off of. It doesn't have to stay in vaccines or preventive care. We can do the exact same model with primary care or other types of gap closures, even if they're not closed in the pharmacy. And so actually we've been able to do that a little bit. It's whether it's regional or statewide. It's what got us to rural health transformation and at the table to be able to share the impact that pharmacies could have there. And I'll talk more about that on another podcast with you all, because that could take us 30 minutes in and of itself. But it's things too, we've been able to share when a payer says, well, are you sure pharmacy can do that? Instead of showing them how many pilots have been provided and proven by pharmacists across the nation. I mean, there's thousands of pilots that have shown this work and the impact of pharmacists. Now we can say, well, yes, and we've scaled it to statewide. We were able to reach patients in over 90% of Missouri zip codes, and that was with 100 pharmacies. Imagine if we opened the door to every community pharmacy in the state and included them as well. Now the impact is even greater.
So how many pharmacies do you have in CPESN right now?
It ranges from 160 to 170. We kind of rotate up and down based on where pharmacies are. We actually have one also not in Missouri that's on a bordering state who participates as well. And so I think active, it's between 160 and 170 right now.
And how many would be eligible in the state? Just out of curiosity, because there's some that are still trying to figure out if this is something they want to do, to spend the money to do it. So.
Yes, absolutely. And that was something we shared a map within rural health transformation to say this is how many pharmacies can get started on day one, but this is how many pharmacies that the doors open this opportunity for. I want to say it's around 400. But there are
for growth. Yeah, that's amazing.
Yes, so but then too, I think the recruitment efforts don't happen unless we have return on investment. So our network also grew in that 2024 program in a 6-month time frame. We grew by 50% without focusing on recruitment, just to say that our pharmacies are impacting and getting paid to do that.
So Annie, the listener on our podcast is driving home from work right now, listening to this and saying, hey, how do I get involved? What's the best way for them to reach out and learn more about that? How do they contact?
Yeah, so they can go to cpsnmo.com, or they can just email me, Annie@morx.com, and I can connect them. We have a lot of luminaries, our leadership, who would be interested in connecting with them if they're in that area. But we also have regional facilitators, so pharmacists, boots on the ground, supporting both quality assurance, communication, and then also building some of these regional relationships that may turn into partnerships in the future.
So most of our pharmacists in the state probably know another pharmacist that's probably engaged. You have these regional folks, they probably just need to reach out and find the name. Okay, cool.
Absolutely. And I'm happy to do that connecting.
Yeah, and some of those regional facilitators actually get on the phone with people or will drive to those pharmacies and visit them periodically. And that's not something you see every day. So, for what does it cost a pharmacy to join CPESN per month?
So per month to join the USA network is $125. Some of that does come back to the local network, but it's really supporting a broader infrastructure. And then for our state, we've recently, last year, added a local network fee of $50 per month, but that includes CPESN-Missouri and then the CPESN Health Equity or Community Health, as it's now known, special purpose network. So for our state, we've really focused on that. I will add that local network fee is what continues to support our regional facilitators specifically. We found so much value in them being able to have that time carved out of their day or out of their week, because they're all pharmacists who are working or owning a pharmacy. So they do need that time carved out to be able to support the entire region. And then they're all the ones who are leading some of our task forces and kind of next steps for our network as well. So that local fee goes directly to pay for our regional facilitators' time.
Good deal.
Well, so Annie, we're winding down here. I know the podcast moves very quickly and you've got so much information to share. So that's why we're going to have to do a part 2. But I always take this time in the podcast to kind of poke at our guest and try to get some information out of them. So we like to try to have our guests tell us a little bit about something that maybe not everybody may know. And I know there's a lot, you're a very visual person. I know you've been on social media and you're very vocal with the people you work with, and everybody knows Annie, but it could be a funny story or whatever, but like to see if you could maybe share something with us, just so we can kind of get to know Annie a little bit more.
Yes. Okay. So I feel like now I've shared this too many times. So I did not choose that I Irish dance and that I'm a certified Irish dance instructor.
Yeah.
That is not my fun fact that listeners would not know. My fun fact, and I told, actually, this is something that not even people that I work with know. So I told them they'll have to listen to the podcast to find out.
Ooh, is
that I've been to Mexican jail. Mic drop. I know. Okay, but it was nothing horrible. Now I had them all guessing, right?
Yeah. I'm like,
so we got in a little fender bender when I was in Mexico with my husband and my mom a couple years ago. And they take everyone to jail and because because they just sort everything out. It keeps everyone in one place. We did not, we went to the jail. We were not put behind bars. But the people that bumped into our car were. So that was kind of interesting. And no one there spoke English. So we had to wait several hours because this was before some of the better translators existed. So Google Translate was not great at the time. It did not work. We couldn't understand a single question they were asking, or vice versa. They did order pizza for us, which was really nice.
That's nice.
So that, you know, by the time the person who did speak English and could translate for us, because we also don't speak Spanish, got there, then we were at least well fed.
That's an interesting fact.
Yeah, that's my fun fact.
So no handcuffs or anything like that?
No, but we did ride in the police truck. And my mom and I sat in the passenger seat, but my husband rode in the back with the other people, which was also really funny because we turned around and they were all taking selfies with him and the police officer back there. So it's also kind of a fun story. Yeah.
Well, thank you, Annie, for being on today. It's been real quick and real exciting to hear some of the great things. I will tell you, every time I go to a conference, every time I have a phone call with somebody, they're always saying, "What are you guys doing in Missouri? I want to learn more about what Annie's doing. We want to connect with you guys." And it's because of you and Trip and Christian and all the people that are so plugged into the state that are fully invested in making sure that this is something that pharmacies have access to. And I appreciate every day the opportunity to be involved in what's going on here in this state. So, Daniel, do you want to close us out?
Yes, thank you, Annie, for being with us today. We really appreciate you being a guest on our podcast. And to our guests that are listening to the Pharmacy Frontiers podcast, we ask them to share this episode with their friends and seek out the previous Pharmacy Frontier podcasts on their favorite podcasting channel. So until next time, remember, it's a good day to be in pharmacy.